Hello, everyone. Welcome to another edition of the CanVector National Thrombosis Seminars. These are monthly seminars hosted live throughout the academic years, which feature state-of-the-art VTE lectures presented by both Canadian and international experts. Video recordings are available on the CanVector website, and you are able to claim Section 1 learning for this activity. This is our planning committee. Dr. Tufei Wang is our chair. So today we have two amazing speakers from the University of Michigan. Today's presentation is about anticoagulant and antiplatelet prescribing in 2024, when less is more. So it's my pleasure to present our speakers. So first we have Dr. Barnes, who is a cardiologist and vascular medicine specialist at the University of Michigan. He is co-director of the Michigan Anticoagulation Quality Improvement Initiative, MAQI, and leads several NIH and AHRQ-funded projects developing, implementing, and evaluating anticoagulation stewardship efforts. He is currently the president-elect of the Anticoagulation Forum. Dr. Barnes, welcome. Thank you for coming. Our second speaker is Dr. Jordan Schaefer. Dr. Schaefer is an associate professor of internal medicine at the University of Michigan, specializing in disorders of hemostasis. He completed internal medicine residency at the Mayo Clinic in Rochester, followed by hematology oncology fellowship at the University of Michigan. Following completion of his fellowship, Dr. Schaefer joined the hematology oncology faculty at the University of Michigan and completed a master's degree in health and healthcare research through the Institute of Healthcare Policy and Innovation. He is part of the University of Michigan Hemophilia and Coagulation Disorders Program. His clinical research interests focus on health disparities in anticoagulation care, cancer-associated thrombosis, antiphospholipid syndrome, and the optimal use of antiplatelet and anticoagulation therapies. These are the learning objectives for today. And lastly, send us your questions. There is time put aside for a Q&A period. So if you have any questions for our speakers, please enter them in the Q&A section, and we will answer them at the end of our presentation. So thank you for attending. Dr. Barnes, Dr. Schaefer, the floor is yours.
Well, wonderful. Thank you so much for that great introduction. And we are thrilled to be here with the CanVector group. You guys are truly the world's experts when it comes to thrombosis and anticoagulation. So it's such an honor for us to get to come and be with you today. I'm going to start things off talking about sort of the clinical space of combined anticoagulant, antiplatelet prescribing, and really asking the question, when can we do less in order to better care for our patients? These are my disclosures. Important that you know that they involve many of the companies that either make, manufacture, or market some of the anticoagulant medications. I thought I would start off with a clinical case, probably one that many of us are familiar with and we see in clinic every day. Think about Mr. J. He's a 62-year-old man. He has a history of unprovoked venous thromboembolism 2 years ago, and he's been on anticoagulation since that time. And he presents to the hospital due to an episode of chest pain. Now, in the hospital, he's found to have an acute coronary syndrome. He's taken to the cardiac catheterization lab, and sure enough, they find that culprit lesion in his right coronary artery. So they go ahead and they place a stent to open up and improve blood flow to the bottom of his heart, or to the right side of his heart. Now, as you're reviewing his medications, you recognize that he's currently using that half-dose strategy of rivaroxaban 10 milligrams once a day for secondary prevention or long-term prophylaxis of his VTE. And so I think at this point, you're getting ready to discharge him from the hospital, and you really ask yourself this important clinical question: how should I select the best antithrombotic therapy to address both his VTE history and his acute coronary syndrome that's now come up, to sort of maximize thrombotic prevention while minimizing his risk of bleeding? So let's jump into it. You know, when we traditionally have thought about approaches to antithrombotic agents, we've really broken them into these two different categories, right? On the right-hand side, we see those who are receiving anticoagulation because of a history of DVT or PE, and you could throw into the mix there things like atrial fibrillation and mechanical heart valves, right? We traditionally think of anticoagulants as being our primary treatment modality there. But on the other side of the screen, you now see the dual antiplatelet therapy, which is what we have traditionally used for our more atherosclerotic processes, things like coronary artery disease, peripheral artery disease, acute coronary syndrome, and the like. And so I think traditionally, thinking back maybe 15 or 20 years, we'd simply treat both of those with whatever antithrombotics were recommended, and you'd add them together for a patient. The problem is we know that when you add them together, that's when patients tend to have the most complications. This is some wonderful data. It's now almost 15 years old, showing that as you combine the number of antithrombotic agents, your risk of bleeding, and particularly the most feared bleeding, I'm thinking about fatal and intracranial type hemorrhage bleeds, they go up significantly, such that if you're on triple therapy, in this case meaning an oral anticoagulant plus dual antiplatelet therapy, you're 3 to 4 times more likely to have that significant bleed than if you were just taking one antithrombotic agent, such as warfarin, aspirin, or clopidogrel. And so really the question is, how do we reduce this bleeding risk while safely preventing thrombosis? And sort of the field all got really excited when the WOST trial was published now more than a decade ago. This was a trial of patients who were taking oral anticoagulation almost exclusively because of stroke prevention and atrial fibrillation. And then these patients were undergoing percutaneous coronary intervention, just like the patient that we saw. And what they did is they said, okay, we know we have to continue their anticoagulant, but let's randomize them so that half of them continue on dual antiplatelet therapy, so clopidogrel and aspirin together, and the other half are going to get clopidogrel only. We're going to drop aspirin from their regimen. Now, if you look on the right side of the screen, this is the one that's labeled any bleeding. You can see here during the 1-year follow-up, which is outlined on the x-axis, that those who are receiving double therapy, meaning anticoagulation and clopidogrel without aspirin, that's the line in blue, that is significantly lower than the patients who received triple therapy, meaning an anticoagulant plus clopidogrel and aspirin. That's the line in red. In fact, the hazard ratio was 0.36, so a remarkable reduction in bleeding. We sort of expected that. But the left side of the screen, I think, really highlights for us the unique and exciting finding here, which is when you look at the thrombotic outcomes, so cardiovascular death, MI, stroke, stent thrombosis, things like that, you also see a reduction when you drop aspirin. So that blue line, which gets out to 11.1% at 1 year, is lower than the triple therapy red line, which is at 17.6%. That's a hazard ratio of 0.6. So I think people got really excited saying, wow, could we reduce bleeding and reduce thrombotic events, or at least maybe not increase thrombotic events by dropping some of our antiplatelet agents? Well, we followed that up with a big trial called the Pioneer AF-PCI trial. This was interesting because it actually had 3 different arms. Group 3 is actually your standard of care arm. This was a group of patients who received warfarin, and then they also received dual antiplatelet therapy. Now, at enrollment, the clinician had to determine how long they were going to receive dual antiplatelet therapy, 1 month, 6 months, or 12 months. So that was sort of our standard group. That's the group that's represented in green. The group 2 was sort of a unique group. They continued on that same dual antiplatelet therapy for 1, 6, or 12 months, but then they were sort of like sprinkled in a little bit of rivaroxaban. They got the 2.5 milligram twice a day dose. You know, this didn't end up getting approved for this particular indication in the United States, so we don't really talk about it a lot, but it is a way to combine sort of a little bit of anticoagulation with your standard antiplatelet therapy. Group 1, on the other hand, this is the group in red. This is the group that we talk about a lot because they got a near therapeutic dose of anticoagulation, rivaroxaban 15 milligrams once a day. It's not the full treatment dose of 20 milligrams, but it's close. And then interestingly, they only got a single antiplatelet. Overwhelmingly, that was clopidogrel. Again, the right side of the screen is your bleeding outcome. You can see that the low-dose rivaroxaban group or the rivaroxaban plus single antiplatelet group, so those are groups 1 and 2, had less major bleeding than group 3, your sort of standard triple therapy group. Hazard ratio here of about 0.6 when you compare groups 1 and 3, so significant reduction in bleeding. On the left side of the screen is where your thrombotic outcomes are. And you can see that groups 1 and 3, the blue and green lines, they essentially overlap during the entire year of follow-up. So no increased risk of thrombosis when you drop that antiplatelet agent. The most robust study in this space was the Augustus trial. Again, AF patients undergoing PCI. In this case, they did a 2-by-2 randomization. So the first randomization was either continue on a vitamin K antagonist or switch to apixaban therapy. The second one was dual antiplatelet therapy or clopidogrel alone. And so they compared all of those. And the figure on the left shows you each of the 4 groups and what their risk of major or clinically relevant non-major bleeding was. You can see that the 2 groups that had triple therapy, so the warfarin in purple and the apixaban in blue, those are your highest bleeding risk groups. The ones where aspirin was dropped, so warfarin plus clopidogrel in orange or apixaban and clopidogrel in green, those are your lower bleeding risk groups. With that, also, apixaban was always lowering bleeding compared to warfarin. In fact, if you switch from warfarin to apixaban, you only need to treat 24 patients to avoid a bleeding event. If you drop aspirin from the regimen, you needed to treat 14. And if you do both together, so if you go from a warfarin triple therapy over to an apixaban-based dual therapy, meaning apixaban and clopidogrel with no aspirin, you only need to treat 9 people to prevent 1 bleeding event. So really, this is high quality evidence suggesting to us we need to do less antiplatelet therapy. So what do the guidelines and guidance tell us to do? This is from the American College of Cardiology and our expert consensus guidance document. And they really have 3 main points here, and I've highlighted them with the stars. The first one, star number 1, says that when a patient who's on long-term anticoagulation, and in this case, it's AFib, because that's where the data was based out of, when they need to have a PCI performed, we should try to switch them over to a DOAC whenever possible. So that's point number 1. The second point is that we only are going to use aspirin for very high-risk patients, and we're going to limit that duration, preferably to like a week or less if possible. So really, we're trying to get to a DOAC plus a P2Y12 inhibitor as our primary treatment modality. The third is because we're combining antithrombotic agents together, everyone should start on a proton pump inhibitor to reduce the risk of GI bleed. Now you follow off to say, okay, how long do I stay on each of these different agents? And it depends on the reason that stent was being placed. If the stent is being placed for stable ischemic heart disease, that's on the left, or if the stent's being placed for an acute coronary syndrome, that's on the right. And what you can see here is the duration and type of antiplatelet agent might differ a little bit depending on what the indication was. But overwhelmingly in both of these groups, they're suggesting oral anticoagulant and single antiplatelet for the first 12 months. That's our main point highlighted in 1. Then after that, we go to oral anticoagulation alone beyond that first 12 months. So really, we're only using antiplatelet agents for the first 12 months after a stent is placed in these combo patients. And the good news is that this is not just a US-based recommendation. This is the exact same recommendation from the Canadian Cardiovascular Society. This is the recent guidelines just published this year, and I've highlighted the 2 important points. They say if you're on an anticoagulant and you need an antiplatelet for coronary revascularization, discontinue aspirin within the first 30 days. Get them down to that anticoagulant plus single P2Y12 antiplatelet agent overall. And then they say after 1 year, stop the antiplatelet and go with anticoagulation alone. So the exact same guideline recommendation as we saw in the ACC guidance document. Now, you may say to me, okay, that's great, but what about a patient with venous thromboembolism? Well, some of our patients with VTE, we're going to continue to treat indefinitely because of their risk of recurrence. So you can think of them like an AFib patient and treat them the same way. But other patients may have a more time-limited therapy for their anticoagulation for VTE. And so in that case, then the ACC expert consensus pathway says, look, use this same strategy of one oral anticoagulant and one antiplatelet as long as you need them to be on the anticoagulant. But if you're going to stop that at, say, 3 months or 6 months, whenever your anticoagulant stops, then you bring back in your dual antiplatelet regimen, and you continue that until they would have finished their coronary treatment. So whether it's 6 months for stable ischemic coronary disease or 12 months for an acute coronary syndrome. So really, you only take 2 pills at a time, but you can switch out your anticoagulant for that second antiplatelet once your time-limited VTE therapy course has completed. So if we go back to our case, right, this was our gentleman who had an unprovoked VTE a couple years ago. He's currently on rivaroxaban. Now he has an acute coronary syndrome. So what should we do? You know, I'm probably going to bump him up from that half dose of Riva to at least 15, preferably 20 milligrams, give him a full dose of anticoagulant DOAC, and then give him that single antiplatelet therapy, preferably clopidogrel, for about a 12-month period. And that's probably the best evidence-based way to treat him for at least this first 12-month period. Okay, so that's really how we think about this combination. What I wanted to do, because I know many of you are going to be more steeped in the VTE space, is I wanted to maybe pull back the curtain a bit in the next few minutes to talk about how cardiologists are evolving their thinking around antiplatelet therapy for patients who have acute coronary syndrome or require coronary intervention. And I'm going to highlight 2 strategies we've been thinking about a lot recently. The first is, can we actually go aspirin-free? Do we really need aspirin when patients are getting coronary stents and for coronary revascularization? And the second is, could we de-escalate the intensity of the antiplatelet therapy? You know, this has been an interesting history. If you go back to the mid-90s, we used to only use a single antiplatelet. We'd usually only give it for maybe a month or so. But then as we got into the 2000s, we started worrying a lot about thrombotic risk. You know, what happens if you get, you know, coronary revascularization and then you have in-stent thrombosis form, or we recognize the ongoing risk of acute coronary syndrome. So we started increasing the duration and intensity of our antiplatelet agents. But once we got into the 2010s, we started seeing a lot of bleeding and recognized how risky bleeding was for patients. So as we've moved now towards the 2020s, we're actually starting to back off on the duration of antiplatelet therapy and the intensity in many patients. So we've sort of seen this pendulum swing a bit in the last 30 years. So when I talk about a short duration of DAPT or an aspirin-free strategy, what I really mean is moving over to a platelet monotherapy at 1 or 3 months, something like that. Whereas de-escalation means going from a high potency P2Y12 inhibitor, something like prasugrel or ticagrelor, and lowering it to one of our lower potency but lower bleeding risk drugs like clopidogrel. So these are the 2 strategies that people are using. If we look at the aspirin-free strategy, you know, there's actually been some data to suggest this may be a good thing. This is actually a study where patients who had a drug-eluting stent placed anywhere from 6 to 18 months prior were randomized to either get an aspirin monotherapy regimen or a clopidogrel monotherapy regimen for their long-term treatment. And interestingly, what you see on the left, these are the thrombotic event rates, is that the clopidogrel monotherapy reduced the risk of those adverse thrombotic event rates. Again, a hazard ratio of 0.73. So we sort of expected that. We think of P2Y12s as being better antiplatelets than aspirin. But on the right side, we saw an interesting finding that there was actually less major bleeding as well, a hazard ratio of 0.7. So we say, okay, maybe you can sort of get a win on both sides here. In fact, if you look at a big meta-analysis of about 24,000 patients, you can see that whether you go with clopidogrel monotherapy or you continue DAPT in patients who are at risk for bleeding, basically shortening the duration, there's no change in adverse coronary events, but you can significantly reduce the risk of bleeding. So this idea of going from DAPT for 12 months down to a shorter duration of DAPT and then switching over to a P2Y12 monotherapy agent is one that's really getting a lot of interest and excitement. But what about de-escalation? What if you feel they still need to be on 2 agents? Well, you could do that too, right? You can drop somebody from those more potent P2Y12s, ticagrelor and prasugrel, and bring them down to clopidogrel. And if you do that, you'd see, at least from this meta-analysis, about a 25% reduction in the risk of those major adverse cardiac events, right? And that, no matter if you're doing sort of platelet genotype guided or platelet function testing or not, which we really don't do a lot, you see similar benefit here. But really the benefit comes in the bleeding side, right? You've got about a 40 to 55% reduction in bleeding when you drop to those less potent agents. And so I think here, again, this idea that less is more kind of continues to flow through. Again, this is embraced by these most recent Canadian Cardiovascular Society guidelines. I've highlighted both of them here where they really talk about de-escalation, but they mean either de-escalation or aspirin-free. And you can see on the left with an acute coronary syndrome, maybe you'll switch after 1 to 3 months over to a single antiplatelet. And then, or you can choose to de-escalate down to a less potent antiplatelet like clopidogrel there. Those are highlighted. On the right, for people who are having the stable ischemic heart disease, so the elective PCI, again, we talk more about that single antiplatelet after 1 to 3 months. And these are new recommendations just in the last year. So this is really where the cardiologists are starting to think about a less is more strategy, and certainly has overlap for those of us who treat a lot of patients on anticoagulation therapy. And it's not just what's been done to date. This is a sort of exciting field that's continuing to evolve. Several trials I've highlighted here since 2019, and several more, 4 more that are ongoing, and we don't even have the results yet. Again, looking at these aspirin-free type strategies, this de-escalation approach. So I think we're going to continue to get more data to help us figure out in whom it's best to use a less is more strategy, how we do that safely, and all of that. So stay tuned, but definitely work with your cardiology colleagues to find the best and safest way to treat these patients. So with that, I'm going to say thank you so much. I'm really looking forward to the Q&A session, but now I'm going to turn things over to Dr. Schaefer to move on to the next part of the talk.
Thank you, Jeff. I'll go ahead and bring up my slides here. Can you see those okay? Okay.
Yeah, that looked great.
Okay. Going to talk a little bit, thanks for the opportunity to present. I'll talk a little bit about, Jeff did a great overview of some of the data on aspirin, and especially among anticoagulated patients. We've been doing some work at de-prescribing aspirin for patients, following current guidelines that have kind of evolved over time. I'll talk a little bit about our work on that. So here are my disclosures. First I'll talk a little bit about aspirin de-prescribing in anticoagulated patients, and then we've done a little bit of work in the primary prevention population. So in the US, and at least for patients followed by our Michigan Anticoagulation Quality Improvement Initiative, which is a collaborative of 6 diverse clinics in the state of Michigan, from starting in 2010 and onward, we observed that co-prescribing of anticoagulant and concomitant aspirin therapy was relatively common in our group. So these are patients largely on primary prevention aspirin who are also on anticoagulation. To the left is patients on warfarin, and to the right is patients on direct oral anticoagulants. And despite data suggesting that aspirin might not be necessary for this group, we didn't see a decline in aspirin use largely over time. So this kind of suggested the need for active intervention to eventually bring about de-prescribing. So we looked a little bit at outcomes in our patient group, the blue line representing patients on combination therapy of warfarin and aspirin compared to warfarin monotherapy. And 3 years out, we were seeing over a 1% difference in the cumulative incidence of major bleeding. From that study, we calculated a number needed to harm of 36 to 91 for major bleeding, and it's been reported that concomitant therapy is associated with a 2-fold risk of major bleeding. So, but we didn't see any, thrombotic benefit for the patients on concomitant aspirin therapy, which kind of led to this, thought about, can we find some people that aspirin deprescribing would be safe and potentially improve outcomes. And so, kind of when thinking about this, we kind of started for patients where they didn't have a high thrombotic risk or patients that were at high bleeding risk, where adding aspirin to full dose anticoagulant therapy would likely do harm. And we also started with anticoagulation clinics for our warfarin treated patients, given that these patients were already being followed by our groups and we had, close communication with these patients and pretty accurate data on aspirin use. So, kind of thinking about, ultimately a lot of these decisions have to be individualized based on individual, patient preferences. But a lot of these patients were on aspirin for primary prevention without or analgesic purposes, that they were taking aspirin, where again, the risk likely outweighs benefit. Others were kind of more on cases where it could be considered, and then we excluded patients with, a strong indication for aspirin, such as recent acute coronary syndrome, or patients with certain types of mechanical heart valves. So, we started, each center kind of developed their own. So for an example of aspirin, de-escalation program, we worked with the clinics, pictured here, and each center developed the intervention in their own way to meet their unique clinical needs. So these are some of the centers that were involved with this work. These are both academic and community practices, both in rural and urban settings. And some, patient censuses of these groups were from the hundreds to the thousands. So they each had unique, needs and ways to adapt this program, but the underlying basis for it was similar. So we started with patients on warfarin for atrial fibrillation or venous thromboembolic disease. For identified those patients that were on aspirin based on often direct interviews of the patient, but also the electronic health record. And then for patients without, we kind of started with the low hanging fruit, patients with no vascular disease at all, or any clear, indication for aspirin. And when that was, apparent, based on, sometimes this was manual review, direct clinical follow-up, or using informatics tools in the electronic health record, the primary care provider or the managing provider would be contacted and asked, if the patient needed to be on aspirin. And oftentimes the providers indicated that their patient didn't need to be on aspirin. And so the anticoagulation clinic would facilitate that discussion back with the patient, saying, your provider has suggested that you might not need concomitant aspirin therapy while on anticoagulation. And so this intervention, largely started around 2019. So we're now a couple of years out in follow-up. When we looked at the data, we saw a subtle reduction in aspirin use. So our historical mean from, dating back to around, 2010 was about, 1/3 of patients on concomitant aspirin therapy. There's a subtle decline starting about, 24 months pre-intervention, and then post-intervention, which was, enacted at different dates at each center. We saw a rapid decline in aspirin use to settle out at around 5 or 10% after about two years of intervention at each of the sites. And we saw that the intervention was, this is monthly patients. So of our cohort of patients that are followed, this is the percent of patients with an event each month. So each dot represents a monthly incidence of bleeding. In this case, major bleeding. And we saw that, the intervention was associated with reduced bleeding over time. So, deprescribing aspirin overall seemed to be associated with less major bleeding events per month with no increase in thrombotic events. So, as far as like the process, each, kind of the main tasks of if you're developing a deprescribing intervention, first step is, identifying the patients. We started with warfarin treated patients and are looking at, now direct patients on the direct oral anticoagulants. Our intervention was based out of the anticoagulation clinic, but other, centers, or especially with the patients on the DOACs not being followed by anticoagulation clinics routinely, the setup for another intervention might be a little bit different. Given that aspirin can be, obtained without a prescription, identifying aspirin use can be, a challenge that I'll cover kind of some of our work on later. Then engaging the provider, encouraging, shared decision-making, but facilitating care coordination. One of the problems we found is that patients are often followed by numerous, specialists, and each kind of pointed to one another to determine who's actually managing the aspirin. If we asked about deprescribing to the primary care doctor, they said ask the cardiologist or ask the hematologist or ask, some other, specialist. And sometimes it was just a matter of coordinating care or educating the patient. So we did have some patients that would, stop aspirin and then, kind of get a little nervous about that and restart it later on. So then, make a decision about, what to do with the aspirin, and we document that in the electronic health record. And then for patients that were high bleeding risk, we worked with Dr. Kurlander, who's a gastroenterologist here, who was able to implement, gastrointestinal prophylaxis, for example, with a proton pump inhibitor for patients, on combination therapy that didn't have any, drug interactions or contraindications that were deemed to be at high risk for gastrointestinal bleeding. So, this first intervention that we had done, started with the warfarin treated patients. And then again, this is kind of, started to go to other populations, such as the patients on the direct oral anticoagulants. Other centers have implemented, at least over 10 centers through the Anticoagulation Forum have, participated in similar interventions. We're continuing to look at, data of aspirin use in some, populations such as antiphospholipid antibody syndrome and that group. So some subsets where there may be more uncertainty, we're continuing to kind of look at, management strategies. And then we've shifted a little bit to look at primary prevention aspirin. Both in our family medicine clinics and internal medicine clinics, are there, opportunities to improve antithrombotic therapy management in that setting? And, when we started to look at that, because as we were doing the, intervention on anticoagulated patients, the trials on primary prevention were starting to come out. And we started with a provider survey, there's at least in the US especially, and I'm not sure if it's the same in Canada, there's this culture that aspirin is, something that's good for, general health. So these are some of the comments, can the aspirin be contributing to my ulcers? That might be a situation where the doctor is not aware that their patient's taking aspirin and that they're, coming in for peptic ulcer disease. There's a lot of questions from patients on, is it still recommended? In some patients are often self-adjusting their medication. Something we commonly hear is that the patients are getting their information from the media rather than talking with their doctors. This emphasizes the role that the anticoagulant, prescriber needs to be engaging their patients on aspirin use and, helping patients determine if it's right for them. And a lot of patients, want to know, is it effective? Do they need to be taking one other pill in addition to all the other things that they've, been on? And, Jeff presented an interesting, kind of history of kind of the trends in antithrombotic, use over time for cardiology population. This diagram, kind of shows some of the trials that have looked at aspirin for primary prevention over the years, and some of the, in the US, the Food and Drug Administration has never recommended aspirin for primary prevention, but largely for secondary prevention. And you can see, over time, the green trials are, positive studies, where the red studies are neutral or negative. And you can see that, culminating kind of here in 2018, where you had the ARRIVE, ASCEND, and ASPREE studies, and the American College of Cardiology, American Heart Association updated their primary prevention guidelines. So I'll talk a little bit about, some of the primary prevention deprescribing work we've done, because it kind of gets at, looking at a different patient population. Aspirin deprescribing for patients followed in anticoagulation clinics that are on warfarin presents a little bit of a different challenge than patients that are in the primary care setting, where you're working with different prescribers and kind of patients that aren't routinely being followed with INR checks and along those lines. So the for primary prevention, aspirin for cardiovascular disease, early trials showed reduction in myocardial infarction and stroke, but not in mortality at the cost of increased bleeding. 2018, there were the 3 large randomized controlled trials with little to no benefit for initiating primary prevention aspirin. They were follow-up of these studies, whereas over 5 years. There's some limitations to the studies, including adherence rates, low overall event rates, some questions on gastrointestinal prophylaxis, and concomitant medications. Meta-analyses that have included these trials, continued to show no reduction in all-cause mortality, increased risk of major bleeding, including risk for intracranial hemorrhage. Other meta-analyses have showed reductions in MI and stroke with no difference in mortality, absolute risk increase of about 0.5% for number needed to harm of 210. One of the potential explanations for differences in the trials of cardiovascular disease and aspirin is that we're doing a better job overall controlling other cardiovascular risk factors. So the latter trials had lower rates of tobacco use, better blood pressure control, and improved use of statins. So something aspirin, given the bleeding risk of adding aspirin for patients, that maybe kind of offset some of the potential cardiovascular events, especially with improved overall cardiovascular care. This figure kind of nicely summarizes those 3 trials. So you have the ARRIVE trial, which was moderate, predicted cardiovascular risk of greater than 20%, which showed similar cardiovascular outcomes with placebo with increased bleeding. ASCEND, and importantly, the event rates were lower than predicted by ASCVD risk scoring, suggesting that we're still having trouble accurately predicting cardiovascular risk, which can be problematic. The ASCEND trial was in patients with diabetes, increased bleeding, but did reduce cardiovascular events with aspirin. And then the ASPREE trial were patients over 70, increased bleeding and increased mortality. I thought this is a nice figure kind of showing, to the right column is aspirin. To the left larger column is aspirin with a statin. When you add aspirin, you see increased major bleeding, and that's kind of goes up as your ASCVD risk increases, and then you see a reduction in myocardial infarction with aspirin, but the statin might be doing some of the heavy lifting, given that statin further kind of amplifies that that effect. Suggesting aspirin might have a lower role, compared to statin therapy. So this is the American Heart Association guidelines recommending against the routine use of aspirin for patients over 70, and then also recommending against aspirin for patients at increased risk of bleeding. U.S. Preventive Service Task Force also updated their guidelines that allow individualization of aspirin therapy for patients age 40 to 59 with increased cardiovascular risk, but recommends against initiation of aspirin for patients over, over 60 years of age. There's still some debate about, patients, so with initiation of antithrombotic therapy, bleeding rates are increased. So there's still some question about, the patient that's been on aspirin for 10 years and, is clinically, stable and hasn't bled. Some modeling data suggests a stopping age of 75 for those patients that are currently on aspirin and tolerating it. But there's still some uncertainty about that, given that initiating aspirin was more represented in the clinical trials. The Canadian Cardiovascular Society guidelines were recently updated, recommend against the routine use of aspirin, but encourage shared decision making, especially for these non-fatal outcomes. And they have a really nice illustration in that paper, which was finally or fully published in February, I believe. So here you have major adverse cardiovascular events. So you show a 0.4% absolute risk reduction, but then at the increased risk of bleeding, including intracranial bleeding. And they have a shared decision-making tool in the appendix of that article, which is interesting. The Thrombosis Canada documents, kind of addresses the combination therapy piece. Consider, generally discourages combination therapy, except for certain, situations that we've, kind of covered. Some discussion of LV dysfunction in previous embolic events, proven TIA or ischemic stroke while on therapeutic anticoagulation alone could be an indication for combination therapy. There's been some publications showing that primary prevention aspirin use has been declining, seemingly without any active intervention in Canada as well, with lower overall rates than what we've observed in the U.S. One recent study suggested the rates had declined from 17% to 10%, which is about what we had achieved with active intervention in the U.S. So this is one Canadian study that published in 2020 from suggesting that about 20% of patients were on primary prevention aspirin, but if you applied the U.S. Preventive Service Task Force recommendations, a much larger population would be eligible for aspirin. Almost 1 million more users would be eligible if following the U.S. preventive guidelines from 2016. I think this is what causes some of the confusion, is that guidelines have changed over time, and there's a variety of recommendations, and so I think that's why aspirin requires particular attention. We also have issues, again, estimating the risk of cardiovascular disease and bleeding. So I'll quickly just go through what we've been doing for the primary prevention aspirin. So we kind of started with this an assessment of the state in our local community. We met with local experts representing all the vascular surgery, neurology, every expert in antithrombotic therapy, and kind of had regular meetings. We then developed an institutional guideline on how primary prevention aspirin should be used. So how do you incorporate all these potential variable situations? We then trained providers on this and have done a pilot test at 2 clinics that we manually abstracted all the data from the affected patients, and we're currently in the process of expanding that to other sites. So this is still kind of preliminary, but when we ask people locally why are they taking aspirin, largely cardiovascular disease risk reduction, but some taking it for general health, pain, colorectal cancer risk reduction. This was a local survey to the left, and then we also did this as a national survey of older adults. This included primary and secondary prevention, but helps with general health, reduces pain. 1/3 of patients, indicating that colon. People could select more than one, but 1/3 of patients indicating reducing the risk of colon cancer as a potential reason they're taking it. And despite data to the contrary, reducing the risk of dementia is some of the reasons people are taking it even for primary prevention. A theme has been that patients are largely taking it because their primary care providers have suggested it. And lots of patients had questions. Large percentage of the group had questions on their aspirin use. We found a lot of gaps in patient understanding on aspirin use as well. Some people indicated they're taking it for their blood pressure or their cholesterol. A lot of the patients didn't quite understand why aspirin was suggested in their concern. And there's also a general perception that it doesn't cause bleeding, which was seen by a substantial portion of our patients. So any intervention to reduce aspirin use should incorporate patient education materials, which is something that we've tried to develop with our intervention. So kind of a couple other, barriers that we've encountered, with developing these aspirin deprescribing interventions. One of the issues, again, is the electronic health record, the accuracy of it in capturing aspirin to identify patients. We've had to engage, multiple physicians to, reconcile various opinions about who should be taking aspirin, because even among physicians, we've gotten different, a variety of opinions. There's been this question on starting versus stopping. So for the stable patient that's been on it, and then kind of environmental factors. So we did look at the accuracy of the electronic health record at our institution in aspirin use, and showed that, in a survey of over 1,400 patients, there was 85% accuracy in terms of the electronic health record saying patients were on aspirin, if they actually were, or not saying they're on it if they were not. The negative predictive value was better than the positive predictive value. So more patients, had aspirin on their medication list that they weren't really taking in this study. So, I think this, providers really wanted a guideline, kind of telling them, how to handle, difficult situations and kind of to guide shared decision-making. So we developed that. And then for the primary prevention cohort, we did interviews with providers, and they thought that a best practice alert would be the best way to, reduce unnecessary aspirin use. So we, developed that using the electronic health record to identify patients. Providers would get an alert that looks like this, and say, hey, your patient, seems to be on aspirin without a clear indication. And so, kind of bringing that to providers' attention. And this alert, if they open it or interact with it, will facilitate, some discussion, documentation, and also insert some patient educational materials. So we found that it's in our local health system, over 10,000 patients are on aspirin that might be inconsistent with current guidelines. On our initial review of our pilot test, about a third of patients discontinued their aspirin after the alert was, after the first 3 months of this alert being put in place in the pilot test site. It also helped encourage reconciliation of the medication list. So, kind of to summarize, the aspirin may do more harm than good for some patients, as I'm sure this group's aware. Patients have a lot of questions about aspirin use and may benefit from education. Patients really go to their primary care providers for some of these discussions. Deprescribing aspirin may improve outcomes and reduce, polypharmacy. Some institutional policy or guidelines seem to be helpful for implementing guidelines into clinical practice. And we've done a best practice advisory alert and a pharmacist or anticoagulation clinic based intervention, and shown some success in our patient population. So I'd like to thank everyone involved with these interventions, and happy to take any questions.
Thank you so much, Dr. Barnes, Dr. Schaefer, for this wonderful presentation. To no one's surprise, there are a lot of questions in the chat for the management of this, challenging population that we see commonly. So I'm going to start from a question for Dr. Barnes from Dr. Carrier. Thank you. Great talk. In your first case, after 12 months of therapy, and when you stop the clopidogrel, do you continue Riva at the dose of 20 milligrams long-term, or do you eventually feel comfortable decreasing to 15 or 10 milligrams?
Yeah, I think this is a great question. And clearly we're going outside of the evidence base here, right? We don't have good trial data. I'll tell you, my personal practice is when I'm combining an oral anticoagulant with an antiplatelet to treat both conditions, I use the full treatment dose of the anticoagulant. So that's going to be either Riva 20 or a PIX5 twice a day, obviously dose adjusted for renal function as needed. When I get to the end of that 6 to 12 month mark, when I'm going to turn off the antiplatelets, I continue to keep them on full therapeutic dose anticoagulation for at least another 12 months. And then after that point, I start to look and say, okay, is this somebody who continues to do well? Maybe we'll think about backing down, especially if there's other bleeding risk factors that are involved there. But if not, we may just continue to keep them at that higher dose, since that's where, again, not great data, but the best data we have is in this sort of long-term secondary prevention phase.
That makes total sense. Thank you so much. A question from Dr. Brandau. Thank you for a wonderful presentation as always. Dr. Barnes, you mentioned antiplatelet monitoring. Would you mind expanding on that, perhaps commenting on the role of point of care testing, platelet aggregation, and ORTEG mapping, please?
Yeah, there's a lot of different things that can be done. And I bring this up because, about 10 years ago in the cardiology community, there was a lot of concern about the effectiveness of clopidogrel because people were concerned, particularly about some genetic abilities to actually metabolize the prodrug into its active form and whether people were getting the full antiplatelet effect. So often they were recommending either platelet function testing or genetic testing to determine whether or not you would be a good recipient of clopidogrel. Essentially, the trials have shown that it doesn't really impact clinical outcomes. So it's not really something that we recommend doing anymore. I just put it on there because some clinicians still like to lean into it. And we basically showed whether you use that as a guided approach or whether you just go ahead and reduce people to clopidogrel anyway, you effectively seen the same benefits from both a bleeding and a thrombotic event rate. So we don't routinely do them at my center.
Great, thank you. Two questions from Dr. Zhu. So among patients who had atherosclerotic CVD on aspirin, I assume non-revascularized, but to be clarified, prior to an unprovoked VTE diagnosed and started on anticoagulation, aspirin stopped during full dose treatment, but then they meet an indication for secondary VTE prevention, but at a higher risk of bleeding. Do you feel comfortable then using low dose DOAC alone without aspirin for arterial CVD protection, or do you continue standard dose DOAC long-term to avoid concurrent ASA?
Yeah, again, this is a place where you're going outside of clear evidence base, and I think it's a great opportunity for that shared decision-making with your patient. In this case, I would say, look, having you on a lower dose DOAC, which is going to offer us protection across multiple indications, is probably better than putting you on multiple agents or a higher dose therapy, which could then lead to bleeding. And we know that bleeding is a prothrombotic state. So I'd probably have that shared decision discussion, but this may be a great opportunity to use that half dose DOAC to sort of cover everything if I'm worried about bleeding risk.
Great. Okay, and another question, I'd love to get your perspective regarding concurrent ASA amongst patients on warfarin for mechanical heart valves. Older literature seems to suggest decreased thromboembolic events, but is this still relevant with modern valves such as the Onyx valve?
Yeah, this is an interesting situation. We're actively working on this right now in our consortium. The latest valve guidelines actually no longer recommend aspirin for patients who are receiving vitamin K antagonists for their aortic or mitral valve replacement. And so we're actually working on deprescribing aspirin in that population. However, the ON-X valves, which we know are less thrombogenic, all of their studies were done with aspirin. And so we're actually finding that when you treat an ON-X valve, you continue aspirin. But if you have a non-ON-X valve, then we're working on deprescribing aspirin. So it's kind of a confusing landscape at the moment.
Interesting. Okay, thank you. Next question is from Dr. Katz. As we move towards single antiplatelet P2Y12 management of coronary stents, should we quote unquote bridge with aspirin when P2Y12 needs to be interrupted for invasive procedures or surgery?
Yeah, that is a great question and certainly an area that's being explored right now. My personal practice is to do that. So if somebody's on, say, clopidogrel monotherapy or ticagrelor monotherapy, and then they need to have a gallbladder surgery or something else, I'll switch them over to aspirin. Usually the surgeons are comfortable with that. It helps me feel better about lowering the coronary and cardiovascular risk perioperatively. And then once they're out of the bleeding window, you just get them back on their P2Y12 monotherapy.
And maybe a follow-up for myself, is that true even after the year after stenting? Yeah.
Yeah, so certainly you're going to bridge them in that year after the stent, right? Because that's our highest risk period. But if somebody's decided to be on clopidogrel monotherapy long-term, then I would probably use that in that situation as well. But I'll also acknowledge we don't have great data. And as we've learned that bridging is not a great idea for our VKA patients, we very well may learn the same thing in that sort of chronic coronary patient. So it's a bit of a TBD.
TBD. I like that. Perfect. Dr. Barnes, we're bombarding you with questions, but another one from Dr. Addis, our new vascular medicine specialist here in Montreal. Many of the new guidelines and consensus statements from AHA-CCS make little reference to COMPASS therapy in stable CAD population at the 12-month mark post-intervention. Could you comment on how you balance COMPASS versus antiplatelet monotherapy in that population?
Yeah, my personal bias, and I want to acknowledge this is definitely me, this is not guideline driven, is I use that dual pathway approach, which is the low dose Riva 2.5 twice a day plus aspirin. I use that for my patients with polyvascular disease, meaning they have peripheral artery disease and usually coronary disease or carotid disease. I tend to not use it a lot in my coronary disease patients because we already have so many other therapies. We've got multiple antiplatelet agents. We've got, statins, blood pressure. We have so many other things that I don't add on a dual pathway approach there. I save it for those highest risk folks with polyvascular disease where we tended to see most of the benefit.
Sounds great. Thank you. And then anonymous attendee, thank you both for this great talk. Question for Dr. Barnes. Can you talk about patients for whom we cannot stop antiplatelet agents after 1 year post-PCI, stent, or CABG, who need to maintain lifelong anticoagulation? How are we defining unstable CAD?
Yeah, lots of questions there. So as I mentioned, those with an on-X valve are ones where I'm probably going to continue aspirin, at least for now, because that's the way their trials were conducted. Another group in which I would continue aspirin is somebody who's probably had multiple coronary interventions, or when I talk with the interventional cardiologist, they say, wow, this was a really tricky stent to place. I'm not overly confident in this person's ability to endothelialize that very well. I'm concerned. Then I'm going to think about ways that we may need to sort of extend aspirin in addition to an oral anticoagulant, as opposed to just going to the oral anticoagulant alone. Dr. Schaefer, I know you often think about some other hematologic conditions where aspirin therapy may be indicated. I don't know if you want to throw any of those out as well.
Yeah, I think a combination, some patients that we've had with myeloproliferative neoplasms, antiphospholipid antibody syndrome, and then we've even had some patients that their gastroenterologist from a colorectal cancer prevention, standpoint has, suggested aspirin, mainly in hereditary, syndromes. So there's a few other, kind of rarely encountered, subpopulations where, we'll continue aspirin therapy for other indications, especially people that have had, breakthrough thrombotic events in other settings. We'll sometimes consider that.
Great, thank you so much. There was a comment about PPIs. I think, Dr. Barnes, you provided a written response, so thank you so much for that. That is all for the questions in the Q&A. Thank you again so much, Dr. Barnes, Dr. Schaefer, for this great presentation. A reminder that the recordings will be available online and that you're able to collect Section 1 Royal College credits for this talk. And with that, thank you again to our presenters, and have a great afternoon, everyone.
Thank you.